Alterations in cardiac output and tissue perfusion, hypertension. Blood pressure, or BP, is the force that's produced by the volume of blood in the arterial walls. Blood pressure equals the cardiac output multiplied by the peripheral resistance. Blood pressure is raised and lowered by neural, hormonal, and chemical mechanisms, and through vasodilation and vasoconstriction. Measurement of the blood pressure reflects the ability of the arteries to stretch and fill with blood, the efficiency of the heart as a pump, and the volume of circulating blood. Blood pressure can be affected by age, body size, diet, activity, emotions, pain, position, gender, time of day, and disease status. We measure blood pressure with a standard sphygmomanometer and a stethoscope. Blood pressure is expressed as a fraction, with the top number being the systolic blood pressure and the bottom number being the diastolic blood pressure. Normal blood pressure for adults ranges from 100/60 to 119/79 millimeters of mercury. To obtain a realistic idea of the blood pressure, several measurements should be obtained for comparison. If we are getting an elevated blood pressure or an abnormal reading, wait about 15 minutes, retake it, and compare it. We also want to make sure that the client has not been up walking or smoking. They shouldn't be talking during this measurement, and the arm should be at heart level. The autonomic nervous system, the kidneys, and various endocrine glands are going to help regulate the arterial pressure. The blood pressure usually increases with age because of arteriosclerotic and atherosclerotic changes in the blood vessels or other effects of chronic diseases. For example, diabetes or renal dysfunction. The systolic blood pressure is determined by the force and the volume of blood that the left ventricle ejects during systole and the ability of the arterial system to distend at the time of the ventricular contraction. Again, older clients may have an elevated systolic blood pressure because of arteriosclerosis. Arteriosclerosis is going to cause vasoconstriction, and that increases that peripheral resistance. In other words, the heart has to push harder to get that blood to go through. So that in turn increases the systolic blood pressure. The diastolic blood pressure is the arterial pressure during ventricular relaxation. It's dependent on the resistance of the arterioles and the diastolic filling times. If those arterioles are constricted, blood will be under a greater pressure. Now, we can do a procedure called a central aortic systolic pressure, or a CASP. This can be a better predictor of vascular and cerebral complications than by obtaining the blood pressure on the brachial arm area, but it may not be practical because of the cost factors. Basically, the pressure of the blood at the root of the aorta as the blood is pumped from the left ventricle is then measured invasively by passing a catheter from the femoral artery to the aorta, or by a Caspro computerized monitor. So the nurse is educating clients at the community center on the risk factors of developing hypertension. Which of the following is considered at the highest risk for developing hypertension? This is B, older adults with diabetes. So hypertension is high blood pressure, and it's known as the silent killer. 1 in 3 adults have hypertension, but only 52% are aware of or have their blood pressure under control. Risks for hypertension include heart disease, heart failure, stroke, and kidney disease. Prehypertension is a systolic blood pressure between 120 and 139 millimeters of mercury and a diastolic blood pressure between 80 and 89 millimeters of mercury. Stage 1 hypertension is a systolic blood pressure of 140 to 159 millimeters of mercury, or a diastolic blood pressure between 90 and 99 millimeters of mercury. Stage 2 hypertension is a systolic blood pressure that equals or exceeds 160 millimeters of mercury, or a diastolic blood pressure that equals or exceeds 100 millimeters of mercury. Hypertensive heart disease is when that elevated blood pressure causes a cardiac abnormality. We may see hypertensive vascular disease where we have vascular damage present without heart involvement, or we see hypertensive cardiovascular disease where both heart disease and vascular damage accompany hypertension. Categories include essential hypertension, also known as primary or idiopathic. 95% of cases have a sustained blood pressure with no known cause. But age or familial tendencies or being of an African American ethnicity may be contributors. Risk factors for essential hypertension include obesity, inactivity, smoking, alcohol, ineffective stress management, hypernatremia, alterations in body chemicals, or impairment in the renin, angiotensin, aldosterone mechanism. Secondary hypertension is an elevated blood pressure that results from or is secondary to some other disorder. It accompanies any primary condition that affects fluid volume or renal function. Risk factors include kidney disease, a pheochromocytoma, hyperaldosteronism, atherosclerosis, cocaine use, cardiac stimulants, and oral contraceptives. And we also see white coat hypertension, and this is a real thing. It's an elevated blood pressure that develops during evaluation by medical personnel. Overall, hypertension damages the arterial vascular system, accelerates atherosclerosis, and can cause complications in other body organs, such as the eyes, brain, heart, and kidneys. So these clients, many of them may not even realize they have hypertension, as it has a gradual onset and they just don't notice these symptoms. They may have a throbbing or a pounding headache, dizziness, fatigue, insomnia, nervousness, and nosebleeds. The size of the heart muscle begins to increase, and we may also see heart failure. We may see myocardial ischemia, which can lead to a myocardial infarction, angina, and dyspnea. Hemorrhage of the tiny arteries in the eyes can cause blurred vision and papilledema. We may see a CVA or a renal failure. We diagnose with an electrocardiography, echocardiography, x-rays that can show enlarged left ventricle. We can also do a multiple gated acquisition or MUGA scan, which detects insufficient heart pumping. We can do blood tests that show an elevated blood urea nitrogen or BUN or serum creatinine levels. We can also do IV pylography, fluorescein angiography, Ophthalmic testing using IV dye and renal arteriography along with a 24-hour urine specimen. Non-pharmacological interventions are going to be used for clients with prehypertension, and that's going to include weight reduction, decreased sodium intake, moderate exercise, reducing smoking, and alcohol use. Drug therapy. Treatment's going to depend on the stage. It may include thiazide diuretics. Most people will need 2 or more antihypertensive medications to reduce their blood pressure. And if the blood pressure remains elevated, a 3rd or 4th antihypertensive agent might be added. So let's talk about some of the medications. First of all, we have our beta blockers, or those medications that end in olol. They are going to not only help with hypertension, but they're going to be beneficial with exertional angina. They're also given with MIs and dysrhythmias, essential tremors, and migraines. It is contraindicated with systolic heart failure, serious conduction disturbances, and bradycardia, because one of the things that happens with your beta blockers is it slows down the heart rate. It should also be given cautiously with diabetes mellitus and PVD. So it does cause bradycardia and hypotension, so we should always check what the blood pressure is and check what the heart rate is prior to administration. If it's below 60, we need to make sure that we are contacting the healthcare provider. It can also cause dizziness, fatigue, wheezing, dyspnea, and mask symptoms of hypoglycemia. Atenolol, metoprolol are 2 of those medications. Our adrenergic drugs are going to be contraindicated with acute heart failure, peptic ulcers, and severe liver or kidney disease. It can have adverse effects of bradycardia with reflex tachycardia, postural and post-exercise hypotension, a dry mouth, drowsiness, dizziness, and sexual dysfunction. Do not stop these drugs abruptly. It does require gradual dosage changes and periodic monitoring of a CBC and BMP. Excuse me. Alpha adrenergic blockers are given for hypertension and BPH, and that can include like our tamsulosin. Then we have our centrally acting alpha agents that are given as an adjunct in hypertensive treatment with other antihypertensives or diuretics. Examples would be like clonidine or methyl-dopa. Calcium channel blockers is the next category. These are given for angina and hypertension. They can also be given for supraventricular tachycardia, coronary artery spasms, and short-term AFib. Contraindicated for acute MI or a 2nd or 3rd degree AV block and hypotension. It can cause hypotension or palpitations or a tachybradycardia, constipation, nausea, dyspnea, rash, flushing. It interacts with grapefruit juice, so should not be given. Example of your calcium channel blocker is going to be amlodipine. Then we have our renin, angiotensin, aldosterone system inhibitors. So our ACE inhibitors, hypertension, adverse effects of fatigue, dizziness, mood changes, headaches, a dry, non-productive cough. This is one that a lot of people are not aware of. And they will say they have an allergy because it causes that non-productive cough, dry cough. Examples would be captopril and lisinopril. So your ACE inhibitors are going to end in pril, P-R-I-L. Then our angiotensin 2 receptor blockers for hypertension, contraindicated in pregnancy and lactation. Adverse effects include chest pain, fatigue, hypoglycemia, diarrhea, urinary tract infections, anemia, weakness, and hyperkalemia. Losartan is the drug in that category. And then our final category is going to be your aldosterone antagonists, often given for severe stages of heart failure and also used to help treat hypertension. This is going to include spironolactone, which is a potassium-sparing diuretic and a synthetic steroid. So adverse effects include dizziness, a headache, abdominal cramps, nausea, vomiting, diarrhea, weakness, and hyperkalemia. And Renin, I'm sorry, I'm not sure how to pronounce that, is a selective aldosterone blocker for hypertension, contraindicated if you have a potassium that's higher than 5.5. So management. Initially, we want to get blood pressure in the client's arms, both of them, with the client in a supine position, and then in a sitting position, and then in a standing position, especially if we're trying to get our orthostatic blood pressures or postural blood pressures. Encourage following their treatment regimen. They don't want to stop these medications on their own. They want to follow the doctor's orders. They need to obtain additional cardiac assessments and medical history. Their current symptoms needs to be monitored. Non-pharmacologic and pharmacologic methods for restoring and maintaining blood pressure need to be taught to the client. Again, the weight loss, the diet changes, non-smoking, non-alcohol, etc. And techniques for self-management and collaboration with the dietitian, including that DASH diet. So here's several different stress relieving techniques that can be taught to the clients, because remember, stress is one of the issues that we have with an elevated blood pressure. Which condiment would the nurse recommend to a client with hypertension who's on a low sodium diet? That's going to be our lemon juice. Most of our condiments are high sodium. Accelerated and malignant hypertension can develop in clients with essential or secondary hypertension. Accelerated hypertension, we have a markedly elevated blood pressure that's accompanied by hemorrhages and exudates in the eyes. This is a hypertensive crisis. Malignant hypertension is untreated accelerated hypertension. Excuse me. And we have dangerously elevated blood pressure accompanied by papilledema. This occurs in clients with undiagnosed hypertension or those that fail to follow up or comply with medical therapy. We may see an abrupt onset, and if untreated, severe symptoms and complications follow rapidly. Malignant hypertension is fatal unless that blood pressure is quickly reduced. Excuse me again. The kidney, brains, and heart may be permanently damaged even with intensive treatment. Arterial blood vessels can rupture or may soon rupture. Retinal hemorrhages can lead to blindness. Stroke can happen. Aneurysms may burst and cause hemorrhage and shock, or pulmonary edema or myocardial infarction may occur, along with renal failure. These clients experience confusion, headache, visual disturbances, seizures, and coma. That rise in the blood pressure can cause chest pain, dyspnea, moist lung sounds, and renal failure. They may have severe back pain accompanied by hypotension, and this is a sign that an aortic aneurysm is dissecting or rupturing. Systolic blood pressure will be 160 or higher. Diastolic is 100 or higher, or both. The optic nerve may appear to bulge forward, and retinal blood vessels are obscured. The goal is to lower that blood pressure within 1 to 2 hours using IV drugs or oral medications for less critical clients, and oxygen to reduce hypoxia-induced tachycardia. Nurses need to implement medical orders promptly, making sure of appropriate dosages and routes, and monitor that client closely with blood pressures. Report a blood pressure of 160 or higher, systolic, diastolic of 115 or higher immediately. Restrict client activity. Monitor for neurologic, cardiac, and renal complications, and keep emergency equipment and drugs readily available in case of complications. So a 38-year-old man has hypertension. He's interested in starting an exercise program. What form of exercise would be best for him? Bicycling. This is the only isotonic exercise that's recommended for hypertensive clients.